Hi, everyone. My name is Jessica Jong. I'm an internal medicine resident at UCLA. And today I have with me Dr. Nissen, whom I have the honor of speaking with on behalf of the ACC Fellows in Training Fits on the Go. So, as a brief introduction, Dr. Stephen Nissen is the principal investigator of the Apollo trial, magnitude and duration of effects of a short interfering RNA targeting lipoprotein A placebo-controlled, double-blind, dose-ranging trial. Dr. Stephen Nissen is the Chief Academic Officer of the Heart, Vascular, and Thoracic Institute at Cleveland Clinic and Lewis and Patricia Dickey Chair in Cardiovascular Medicine. He was previously chairman of the Department of Cardiovascular Medicine and medical director of the Cleveland Clinic Cardiovascular Coordinating Center, an organization that directs multi-center clinical trials. Dr. Nissen's research and clinical interests over the last 3 decades have focused on general cardiology, intravascular ultrasound, diabetes in the heart, drug safety, and coronary intensive care. Welcome, Dr. Nissen, to Fits on the Go.
Well, thank you for having me. It's a pleasure to meet you again, as you were a student here.
Great. Thank you for your time and for all the seminars you gave too. So I guess as an introduction, would you mind sharing with us some background on lipoprotein A and the objectives for the trial?
So for any of you that have not encountered it, lipoprotein A is one of the most important cardiovascular risk factors that has not yet been adequately addressed. It's genetically determined. Diet, lifestyle, statins, no other pharmaceutical interventions have any effect. About 20% of the global population have levels above 60 milligrams per deciliter, which is approximately 150 nanomoles per liter. That means 64 million Americans have this abnormality, and about 1.4 billion people on our planet have this very important risk factor. It produces cardiovascular disease because it has dual actions. The core is an LDL-like particle, and there's a protein, ApoA, associated with that lipid that is prothrombotic. And so we talk about atherothrombotic disease. Lipoprotein A, in fact, promotes both atherosclerosis and thrombosis.
Thank you. That's very helpful. And I think we're seeing from all the research that it is an independent genetic risk factor for cardiovascular disease. So it's very important. In terms of the Apollo trial, what were some of the objectives that you're looking at?
Well, first of all, obviously to approach this disease, there really is no classical pharmacological approach. What we have to do is find a way to prevent the production of lipoprotein A. The gene is the LPA gene. It makes messenger RNA, which is then translated to ApoA, which is the rate-limiting component in the formation of lipoprotein a. So what we are working with here is a short interfering RNA. What it is a double-stranded short RNA, 19 sequences, that can be given subcutaneously. It's conjugated with a sugar known as GalNAc, which is derived from galactose. There are receptors in the liver that take up the GalNAc, and they carry the short interfering RNA into hepatocytes. The double-stranded RNA then splits into a sense and antisense strand, and the antisense strand combines with messenger RNA that was produced by the LPA gene, and it degrades it. If you don't have messenger RNA for apolipoprotein A, you don't make Lp(a). And so we were testing in an early phase 1 trial whether this strategy would work and whether it would be tolerable, and to some extent, whether it would be safe.
That's fascinating, really getting at the mechanism.
Yeah, this is sometimes called gene silencing. It's kind of it's a new frontier in pharmacology, not just in cardiovascular medicine, but across many disciplines. We can prevent the formation of any protein with these what are called RNA interference strategies.
That's great. And would you be able to share with us what were some of the key findings in the trial?
Yes. So we studied, of course, it was a placebo group. It was a single ascending dose trial of 30, 100, 300, and 600 milligrams. Given a one-time injection in a clinical research unit, people were very closely observed, and then followed for 150 days thereafter. The top two doses, the 600 and 300 milligrams, produced a 98% reduction in LP little a for 600 milligrams and a 96% reduction with 300 milligrams. The nadir was somewhere between 30 and 60 days, and then levels gradually rose, but after 150 days, for the top dose, they were still 81% below baseline, and for the next highest dose, 300 milligrams, they were 71% below baseline. So very strong efficacy and very long duration of action.
Wow. Was there much in terms of adverse events that you saw in the
So
trial?
all of the RNA therapeutics, and there are several now on the market, such as inclisiran, for example, which I think many of you probably use by now. All these RNA therapeutics, they get a little injection site reaction. They tend to be low grade. They go away in a few days. It's kind of like getting a COVID vaccination, or some other vaccination. You get a sore arm.
Mhm.
We're not worried about that. We watch hepatic safety carefully. We had a single patient who, right after COVID vaccination, had a very brief increase in liver enzymes, came right back down to normal. We don't think it was drug related. So now it's only 32 patients. So I can't really say much definitively about safety in an early phase 1 trial with a single dose, but it's promising, and we're going to find out more when we start giving multiple doses and as we move into phase 2.
That's great. What are some things that we should keep an eye out for in terms of next steps and where the research is headed?
So for the treatment of Lp(a), which the New York Times called the heart risk factor even doctors know very little about, big article that they had. Couple things. One is, all of you should be aware, particularly in patients with premature cardiovascular disease, you need to find out what their Lp(a) level is. And if it's high, you need to test their first 3 relatives. I can't tell you how many people I've seen that have levels that are super high, and no one's ever told them to have their brothers and sisters and children tested. So that's important.
Because of this.
So awareness is important here. I think all of you should know we have 3 shots on goal. We have a drug called pelacarsen that's in phase 3, and we're doing a very large cardiovascular outcome trial with it. It's not an RNA therapeutic, it's a DNA therapeutic. So it's called an antisense oligonucleotide, kind of similar mechanism, but a little different. And then Amgen now has another short interfering RNA. So we have 3 drugs in development. We're hoping that one of them will turn out to be, or maybe all of them will turn out to be, both safe and efficacious and reduce cardiovascular events. This therapy will not come to market until we demonstrate not just that LPA is a risk factor, but that lowering LPA lowers cardiovascular risk. That's the big next step.
Wow, that's really interesting. And that'll take some time before those studies result?
Well, the phase 3 study with the ASO, the antisense oligonucleotide, which I happen to be chairing, is fully enrolled, ongoing. It's at something like 1,000 sites globally. We're moving fast, but it takes time. You got to accumulate enough cardiovascular events to see whether or not there's a difference between usual care plus placebo versus usual care plus a LPA lowering drug. We're very excited that this last frontier in the treatment of lipid disorders that are common, we are about to find a solution. We got great drugs for lowering LDL, lots of things that we can do, blood pressure, diabetes control, but we've never been able to treat lipoprotein little a, and it's causing tremendous problems for patients. I want to make sure one more thing is understood. It's not only a risk factor for ASCVD, but for more rapid progression of aortic stenosis, for development of AS and progression of AS. So we have a chance to affect both diseases and to affect patients that are getting these diseases at an earlier stage in life, where we would really like to be able to intervene.
Wow, that would be amazing, truly. I guess in terms of a summary, then, Dr. Nissen, would you be able to just recap for us what are some key takeaways that trainees should walk away with?
LPA is important. Everybody should be measuring it more often. Our study, Apollo, showed that a short interfering RNA could block the production of lipoprotein A with a high degree of efficacy and apparently good safety. And stay tuned, watch this space, because in your careers, I hope you will be able to prescribe these drugs to help patients with this disorder.
Thank you so much for your time, Dr. Nissen. I think that really sums it up beautifully. And I'm sure we're all going to be keeping an eye out for the Apollo trial and for future research on lipoprotein A and how we can help our patients. Thank you so much.